Hello and welcome. My name is Eli and I'll be your moderator for today's event on paragangliomas and pheochromocytomas regarding surgery. I'm a multiple cancer survivor myself, a dad, and a volunteer for the Pheo Alliance. Like some of you on this call, I suffered from a metastatic pheochromocytoma for 10 years or so. I know what you're going through. It feels like a lion is chasing you each and every single day of your life. However, I'm here as living proof that there's not only hope, but once you reach remission, there's a calmness unlike anything I can describe to you on today's webinar that's waiting for you on the other side. All I can say is you'll recognize it when you get there. We are so fortunate today to have doctors highly specialized in this disease state, and they're ready, willing, and able to teach us about our disease and help us find a path to recovery. So please, engage today's speakers with questions because after all, you're your own best advocates. We're here today with Dr. Michael Ye and Masha Livitz. We will provide proper introductions here in a few minutes. This program is provided to you by the Pheo Alliance, whose mission is to empower patients who are suffering from pheochromocytomas and paragangliomas, as well as their family and medical professionals with advocacy, education, and a global community of support while helping to advance research and accelerate treatments and cures. A special thanks to Progenics for making this webinar series possible through an educational grant. It's no doubt that we're living in strange times right now, and we're all trying to figure this out. With our lives disrupted due to the pandemic, we're doing our best, to stay safe at home and just know that we're thinking about you. And in fact, speaking of, tomorrow there's going to be a COVID-19 webinar at 3 p.m. Pacific, 6 p.m. Eastern Standard Time. So link to register at pheopara.org. Sign up for our e-news, and again, follow us on social media. So to go over some of the agenda and questions, I'll take a few minutes to do that. The doctors here will present for about 30 minutes, and then there will be Q&A from the community. We will ask submitted questions beforehand, and you can also submit your questions into the chat section. We'll do our best to have all of your questions answered if time allows. Many people will have the variations of the same question, so please listen carefully for the questions that are similar. Questions that are less case-specific would greatly be appreciated. And to that end, we have a disclaimer that the information presented on today's webinar is for educational purposes only and should not substitute the advice of your doctor and medical team because they have an in-depth knowledge of your medical history and current situation. So without further ado, I'd like to introduce the doctors. Dr. Michael Ye established the UCLA endocrine surgery program in 2006. After pursuing his studies at Stanford University and Harvard Medical School, Dr. Ye trained in general surgery at UC San Francisco and completed a fellowship in endocrine surgery at Royal North Shore Hospital in Sydney, Australia. Dr. Ye is an expert in minimally invasive parathyroid surgery, thyroid cancer, and adrenal tumors, including pheochromocytoma. He has published more than 100 scholarly articles and book chapters on these topics. Dr. Masha Livitz is an endocrine surgeon and assistant professor of surgery at UCLA. An exceptional achiever since childhood, she attended college at the age of 12. She received her medical degree at Washington University School of Medicine in St. Louis and was awarded the prestigious Sarnoff Foundation Genetics Research Grant. Dr. Livitz is published widely in the area of improving surgical outcomes and quality of care. She helped to pioneer the new technique of single-incision retroperitoneoscopic adrenalectomy in North America. Wow, that's impressive. The only 12 I got in college was on a math test, so hats off to you guys. So we're going to go ahead and turn it over to the doctors to do their presentations. They'll be doing this via screen share from the comfort of their office.
All right, hi, I'm Dr. Masha Livitz.
Michael Ye.
And we today will be talking about surgery for pheochromocytoma and paraganglioma. I think especially during this difficult time that we're all facing, it's important for us to all be connected and to communicate and to address any questions that people might be worried about at home. So we won't give too much background. I know this audience is very sophisticated and familiar with the background knowledge, but just to make sure that we're all kind of starting with the same baseline knowledge, The adrenal glands are located over here. These fairly small structures here on top of the kidney. And there are two adrenal glands, one on the right, one on the left side. And they produce hormones that are essential. The steroids are the most important hormones that the adrenal glands produce. And then other hormones like adrenaline hormones, which are related to pheochromocytoma and paraganglioma syndromes, and hormones that control blood pressure. So let's talk about what a pheochromocytoma is and how that's different from a paraganglioma. Both of these tumors produce too much adrenaline hormone. Specifically, those are epinephrine, norepinephrine, those are the two most important ones, and then dopamine. And these are the hormones that control our fight or flight response. Most of these tumors are located within the adrenal gland itself, and in that case, they are called a pheochromocytoma. And then the ones that are located outside of the adrenal gland are called a paraganglioma. So a paraganglioma is just a pheochromocytoma that is located outside of the adrenal gland. And if it's located outside of the adrenal gland, where would it be? Usually it's still within the abdomen, but sometimes it can be in the chest or it can be in the head and neck. So all of these little points here show where a paraganglioma may be. So what are the symptoms of a pheochromocytoma or paraganglioma? Commonly, these are episodes of headache, sweating, or racing heartbeats, sort of feeling like you're having this flight or fight response, but it may be inappropriate for the situation. So it might be triggered by exercise, emotional stress, or it may even wake you up out of sleep, for example. And some people don't have those kinds of classic episodes, but they just have high blood pressure, either episodes of high blood pressure or just sustained constant high blood pressure. So as I mentioned, it can be triggered by certain things like exercise or stress, or even specific foods like red wine, chocolate or cheese, which we all love. Or it can be totally untriggered and just wake you up out of sleep. The hard part is that these kinds of symptoms are pretty vague and can be fairly common. They can mimic, for example, anxiety or panic attack, or a lot of people have high blood pressure. So when people just have these symptoms, they're not really specific for a pheochromocytoma, unless you have a family history. So if you have a known hereditary syndrome and then you have these symptoms, then we have a high suspicion of pheochromocytoma. Otherwise, these symptoms are not too specific.
Yeah, I was telling Eli earlier, we saw a boy this morning who very likely has paraganglioma syndrome. He was a 17-year-old cross-country runner, and he gave a textbook story for pheochromocytoma. And he said, well, for the past couple of years, I have these drenching sweats. I'm soaked in sweat. And at the same time, I feel like my heart is racing. It's bounding out of my chest. Sometimes the beats are irregular. It was such a compelling story. And when I asked him, are you ever awakened from sleep with these episodes? He says, yeah, absolutely. I said, do you notice any triggers? He says, yeah, I'm just getting warmed up for my hurdling event, and I barely warmed up at all, and I'm already just dripping with sweat. And he's like, well, I thought it was just the warm up, but sometimes it's more sweat than I would expect. So he had a really compelling story.
Yeah, so that's such a classic history. Yeah. And in hereditary cases that are associated with a genetic syndrome such as VHL or MEN, often those patients present at a younger age and have multiple areas of disease. So this is sort of a schematic of what the most common hereditary syndromes are that are associated with pheochromocytoma. I won't go into all of this in too much detail, but I just want to point out that these syndromes are associated with specific mutations, and then also specific other tumors, for example, or other clinical features. So it's important to know about because, for example, in MEN, those patients might also have a thyroid cancer called medullary thyroid cancer. And then there are also specific characteristics of a pheochromocytoma depending on what kind of syndrome you have. So in MEN, for example, you are likely to have a pheochromocytoma. The chance of developing a pheo in your lifetime is 50%, but most of those pheos are benign. They are not cancerous. They can be bilateral, meaning the left and right adrenal glands, but they're typically in the adrenal gland and they're typically benign. With von Hippel-Lindau or VHL, also they are typically benign. And the chance of getting a pheo if you have VHL is about 10 to 20%. And then we want to pay special attention to familial paraganglioma syndrome associated with SDH mutations, because SDHB specifically has a high rate of malignant pheochromocytoma. So in most of the other cases of either sporadic pheochromocytoma or other hereditary syndromes, these are benign and not cancerous tumors. But with an SDHB mutation, there's at least a 50% chance of having a malignant or cancerous pheochromocytoma.
Yeah, so when we say a cancerous lesion, those are the ones that can regrow. They extend little roots in nearby tissues. They can spread via the bloodstream to weird places like the lung or the bones or the liver. Thankfully, most of the pheochromocytomas and paragangliomas we encounter are benign and curable with surgery.
Right, so how do we detect a pheochromocytoma or a paraganglioma? And it's really with biochemical testing with the laboratory tests. We talked about the classic symptoms, but also mentioned that these symptoms are not specific for a pheochromocytoma, and so we really need the lab testing. And it starts with checking the adrenaline hormone levels. Those are called fractionated metanephrines, and it actually checks the epinephrine and norepinephrine levels so that we can see if there's too much secretion. There are two ways to get it. One is with a blood test, one is with a 24-hour urine test. And nobody likes to collect their urine for 24 hours, but that is probably a more accurate test in most cases. And the reason is that the blood test can have some false positives. So you're supposed to be laying down in a quiet room for 30 minutes before you get the blood test drawn. That's very hard to do in a lab. And so if you don't do that, it's more likely that you just have an elevation and it's a false positive, not a real positive. And so we're really looking for a level that's very high. So let's say that the normal range in the lab is from 50 to 100. We're looking for a level that's 200 or higher. And the reason is that if you have just a very minor elevation, that's not necessarily pheochromocytoma. Usually the hormones are very high if you have a pheochromocytoma.
This is a really important point. What we're getting at is there's no such thing as a perfect test, right? And so any test is going to have some false alarms and also some false negatives. The thing to remember here is that, like, if I jump out of a closet and scare you, your adrenaline levels are going to go up for a few seconds. So what we really want to know is how much adrenaline is being secreted throughout the entire day. And that's why the 24-hour urine test is such a good test, because it gives you not just what's going on in that moment, but what's going on for the whole day. And we get a lot of problems here in our office from people with false positive blood tests for pheochromocytoma. It causes so much confusion. So if there's any message, is the urine test is generally more reliable. It is inconvenient, admittedly, but it has fewer false positive tests. So it's the one we prefer.
Yes, and it's really this lab testing that should be the first step. And if that's positive, then that is followed by imaging the body to detect what is the cause of this elevated adrenaline level. And because most of these are located within the adrenal glands, we usually get a CT scan or an MRI of the abdomen first to detect a pheochromocytoma within the abdomen in the adrenal glands. There are more sophisticated whole body scans that can be done, a special PET scan called a dotatate scan or an MIBG scan that we sometimes do if we're looking for multiple areas of disease. So we have some examples here. So for example, here you can see this is in the left adrenal gland over here, a pretty large tumor there. And then over here, this is another CAT scan. You can see the kidney here with the arrow. And then located in red, you can see that this is a pheochromocytoma on the right side. And then these are the special types of PET scans or dotatate scan, for example. Then you can see there's a tumor here in the left adrenal gland, and you can see that it lights up on the PET activity part. So it helps us to confirm that it is indeed a pheochromocytoma. And then the PET part, you can see, is also scanning the rest of the body. So it's scanning the chest, for example, and making sure that there are no additional sites of disease for spread. Okay, so what is the treatment for a pheochromocytoma or paraganglioma? It's in most cases, it is surgery. And we want to point out that surgery does provide a long-term cure in about 90% of cases. That may not be the experience of everybody who's listening. And part of it may be that if you have a hereditary syndrome, for example, you're more likely to have multiple areas of disease. But in most cases, with one good surgery, there is a durable cure. Okay. The specific case of an SDHB mutation, as we discussed earlier, there's a high rate of malignancy or it being cancerous. And those are obviously more difficult to cure with a single operation if they end up spreading. So this was Dr. Ye's point earlier, what is a malignancy? And this is a spread of the tumor from the original site to somewhere farther away, like the lymph nodes surrounding the tumor or the liver or the bone, something like that. Some people have what's called multifocal disease. That just means that there is a tumor in more than one area. It has not spread from one adrenal gland to the other adrenal gland. It has just occurred first in one adrenal gland, and then a new tumor has arisen, for example, in another adrenal gland or in the neck. And typically, these cases are associated with a hereditary syndrome. The multifocal tumors can still be curable. The malignant ones that have spread are much more difficult to cure.
Yeah, this is an important concept, the difference between multifocal disease and malignant disease. A lot of people with SDH mutations are going to have multifocal disease because the chromaffin cells of the cell of origin are spread. You probably remember this, the diagram from a few slides ago. They're spread all along from your ears, sprinkled along all along your spine and down into the adrenal gland. I often like to say it's like little breadcrumbs spread all around, like that fable Hansel and Gretel. And if you have a mutation that predisposes you to a mutation, it means that in any given day, there's a bit of a roll of the dice that a new tumor could initiate to start anew along that entire trail of breadcrumbs. There are people who need more than one operation for a multifocal pheochromocytoma or paraganglioma who can still be cured. It's the malignant cases that are harder.
So how do you prepare somebody for surgery? And in most cases, we're talking about an adrenal surgery for a pheochromocytoma. The most important part is this preoperative blockade. These tumors release hormones, particularly when you manipulate them during surgery. So during the surgery, we need to push on the tumor a little bit to be able to remove it. And when we push on it, it will release hormones that can make your blood pressure really spike up high and your heart rate as well. And that can be dangerous during surgery. And so we really want to block those hormones before we ever get to the operating room. And there are a couple of different ways to do that, but the best one, the best studied medication is a group of medications called alpha blocker medications, and they block the hormone levels and control the blood pressure. And we want to start them at least 2 weeks before the surgery so we can make sure that their hormones are really well blocked. Also, the blood vessels tend to be very constricted or sort of squeezed down with these tumors. So as we're giving this medication, the blood vessels relax and dilate to the normal status, and that allows you to hydrate, drink a lot of water, eat salty foods. That way, once the tumor is removed, you don't have a crash with a low blood pressure after removal of the tumor. So if we get this blockade just right, then the blood pressure is very stable during surgery and also after surgery. So the kind of longest study medication is called phenoxybenzamine, and it's one of these alpha blocker medications, and it provides very good blockade of the adrenaline hormone. However, it has some side effects, particularly fatigue, stuffy nose, which really just tells you that it's working, so we look for that sign. But I think one of the biggest problems has been the cost of this medication in the most recent couple of years.
Yeah, true. We have a problem in this country with so-called orphan drug problems. Like there are drugs that are used very uncommonly. There's something wrong with the market for these drugs. So more and more we're finding that phenoxybenzamine might be a little too expensive or unavailable for some people, so we tend to use doxazosin or terazosin, which seem to work about as well.
That's right, and we've actually been doing a research study at UCLA looking at these different medications, and it does seem like all of these alpha blocker medications tend to work well for our patients, but the main difference has been in cost. And then after we have the blood pressure well controlled with one of the alpha blocker medications, sometimes the heart rate goes up high, and in that case we treat with a medication called a beta blocker to specifically lower the heart rate. So this is an example of how we do this with our patients. We usually have the patient first either come into clinic or we have a telemedicine visit with the patient if they live at a distance. And then we start the medication. So for example, you can see at the top here, this patient has started an alpha blocker called doxazosin, and they start it here. And then daily at home, they record their blood pressure and heart rate, both sitting and standing, and they email this to us every 2 to 3 days, and then we tell them how to adjust the medication. So you can see here that they're going up from 2 to 3 milligrams, and then at a certain point here, we also start the beta blocker called metoprolol because the heart rate is going up. So we can do all of this when the patient is at home, and then once we have the blood pressure right where we want it to be, we proceed with surgery.
This is a spreadsheet that one of the patients made for herself.
That's right.
And it's so great to be able to communicate electronically with our patients, and the more responsible we can be together prior to surgery. I mean, I just look at this and I'm like, oh, I know this operation is going to go great, you know, because we've done our homework in advance.
That's right. And these are our goals. We want the blood pressure to be pretty low, less than 120/80. Sometimes patients question, my blood pressure is actually getting a little too low. But that's a good thing, because you have to imagine that during the surgery and manipulation of the tumor, it might get a little bit higher. So we actually want it to be as low as possible before the surgery. So just sort of an overview of how we actually do the operation. So on the right side, the adrenal gland is sitting here. So this is the liver here, and then the kidney on the right side, and the adrenal gland is sitting behind here, behind the liver. So if we remove, let's say we flip the liver up and you're no longer seeing it, here is the adrenal gland on the right side, and the main point to make here is that this is the vein that drains the adrenal gland, and this is the main blood vessel that we need to control and divide in a safe manner to do the surgery. On the right side, this adrenal vein is going right into the main vein here that drains blood from the lower part of the body, the inferior vena cava. And so it's a pretty short blood vessel here. There's a little higher chance of bleeding on the right side because we have to really carefully control this adrenal vein on the right side. And if we were to injure it, we may have more bleeding because it's a short vein draining directly into this major inferior vena cava vein. And this is a picture from an actual surgery. You can see here is the adrenal vein, again, going into that major blood vessel here, the IVC, and then here is the pheochromocytoma that's kind of pushed away here. So on the left side, here you can see the adrenal gland, and you see it behind the stomach is over here, and the pancreas, the spleen, and the kidney that's on the left side. So if we move some of those things away so you can see behind them, this is the left adrenal gland here, and the blood supply is a little bit different. So here is the adrenal vein that's over here, and it joins with the renal vein before it goes into that big blood vessel, the IVC. So there's a little bit more latitude, a little bit sort of easier to divide this, and a little bit less risk of bleeding on the left side. And so here's a picture you can see from surgery, that this is actually the tumor, the pheochromocytoma that's pushed up here, and then this is the adrenal vein over here that's going to drain into the renal vein, or the vein draining the kidney. So the keys to successful surgery, number one is this preoperative blockade that we talked about with the alpha blocker medication. If we get that just right, the blood pressure and heart rate should be really stable during surgery. And part of that is having an experienced team. During surgery, the experience of the surgeon and the anesthesiologist, we really cannot overemphasize that. That is so important to have the communication between the surgeon and anesthesiologist. Not only a surgeon who's comfortable doing the surgery technically, knows how to handle the blood pressure fluctuations, but the anesthesiologist who's prepared to give the medications necessary to keep your blood pressure and heart rate stable during the operation.
Yeah, this is so important. And some of you may be out there looking for a surgery team. And the best message we have is you're really looking for a surgery team, not just the surgeon, but the anesthesiologist. You never want to be the first person or the only person in that year who has this problem, right? So here at UCLA, like we're really lucky. We got to say, you know, every 2 or 3 weeks we see somebody with one of these problems, and we just email our anesthesiologist. They're like, yeah, you know, we're ready. It's the same 4 people. We do it every time, and this may sound strange, but our whole goal is to turn an exciting operation into a really boring operation. We like boring. You know, boring is good in surgery, and it's good in air travel. And if we can take one of these rare cases, 1 in a million tumors, and make it just routine and boring, then we're helping.
So then some other sort of important technical points. To prevent this from coming back or recurrence, we really don't want to break into the capsule of the tumor. Even if the pheochromocytoma is benign and not cancerous, If we break into the capsule and spill some of the pheochromocytoma tissue, it can come back with a local recurrence. So we really want to be careful to prevent that. And so you can see in the picture down here on the left, here is where the tumor is. And this is all the surrounding normal adrenal gland and fatty tissue around the adrenal gland. And so we want to take a nice surrounding rim of tissue so we don't break into it. And this is when we cut into it, you can see what it looks like on the inside. And then controlling the adrenal vein, which we showed you the difference on the right and left side to prevent bleeding during surgery or after.
And we only cut into this tumor after it's removed from the body. So usually we liberate the tumor from all its blood vessels and attachments. We throw it into a Kevlar bag. We close the bag. We remove the bag. And then on the back, sometimes we like to fiddle around and look at the tumors because we're geeks. But if it goes well, it's a fun little operation.
That's right. So this was the team that we talked about. These are some of the key members of our team. And the three gentlemen here on the screen left are all our anesthesiologists who do most of our pheochromocytoma cases with us. And they always have a consultation with you as well in addition to us before the surgery, so they're aware of the patients. And this is just to show you kind of the importance of the anesthesiologist and how the blood pressure can change during the operation. So the kind of top red line here is what's happening with the blood pressure. So you can see the blood pressure starting at around 120s, 130s. This is a patient, whose tumor was actually quite reactive. So as we're manipulating the pheochromocytoma, the blood pressure actually gets up to the 190 range. But the anesthesiologists are doing a great job. They're giving the medication. And then here is when we tell them we're about to divide the adrenal vein. That's around here. And as soon as we do that, the blood pressure usually drops right away. So the anesthesiologist is prepared to give medications if it's necessary to actually raise the blood pressure and keep it stable. But so they do that, and then look what happens here. The blood pressure goes up again. Why does that happen? This is a rare case where the patient had actually 2 adrenal veins. And so we saw that what the activity was, that even after we divided one vein, the tumor continued to be active and to secrete hormone until we actually divided the second adrenal vein. So it's very important to have an experienced anesthesiologist as well as a surgeon and excellent communication between the teams.
Yeah, there's a lot of chatter back and forth. So in these operations, we've got all these monitors hanging from the ceiling. We've got the blood pressure, really everybody's staring at it. Everybody's, there's this continuous back and forth conversation that makes it safe. And this just shows how humbling surgery is, right? You think you've seen it all, or you do enough cases and somebody shows up with 2 adrenal veins and you think you're in the clear and you're not. Of course, the vein is important because that's where all the hormones are pouring out of the adrenal gland into the rest of the body to make the heart go crazy and things like that. So we're always very thankful to have the support of these anesthesiologists. And we have a 4th member who just joined, and it's a lady. So it's both men and women on the team.
Okay, so in terms of the surgical technique, laparoscopic surgery is really the standard of care if it can be done safely and successfully. So laparoscopic, unless it's too big, there's not a specific size threshold, more dependent on the experience of the surgeon, or if we're concerned that it's malignant, and in that case, we sometimes will do it open to really make sure that we remove the entire thing. Compared to open surgery, laparoscopic surgery has fewer complications in terms of bleeding, infection and pneumonia, faster recovery. And then there's a question of, are we going to do it from the front, which is the more traditional transabdominal technique, or do we do it from the back, which is the retroperitoneal technique? Both of these are done minimally invasively through those small little laparoscopic video incisions. But you can see here, this patient is having the surgery from the front with the 4 little scars along the rib cage. And the patient is having it done through the back, through 3 small little incisions from the back. And so do we do it from the front or the back? I mean, the main thing I want to tell you first is that the laparoscopic surgery, either way, is an excellent operation. And I think that overall, they have fairly similar outcomes. So it's really dependent on the experience of the surgeon and the best way that they know to get that operation done. But I think if you have the luxury, like we do, of being able to do it in both ways, there are some advantages to doing it from the back or a retroperitoneal approach. damaged. I showed you all those organs that are in the front, the liver, the spleen, the intestines. When you're doing the surgery from the back, none of those organs are actually in your field or in your area of surgery. So we don't have to dissect any of those organs. So that does lead to a little bit of a faster recovery and no scarring from the front. So I think the main advantage of being able to do it from the back is that the recovery is a little bit faster. The other thing is that in the front, sometimes people get hernias in their incision. That's very rare to have that happen in the back. So in our experience, we do most of these operations from the back. The main limitations are if the tumor is too big. I listed a size threshold of 6 centimeters, but even pheochromocytomas up to 8 centimeters can be done from the back. There's also a question of body happiness. If there's too much fat tissue around the kidney, then it can be difficult to do the surgery from the back. So in most cases, we remove the entire adrenal gland so that we can make sure that we get the pheochromocytoma removed, and because the other adrenal gland is still in place. So as long as you have one adrenal gland, then you don't need to be on any hormones or steroids after the surgery. However, especially patients who have a hereditary syndrome, they're at risk for having tumors in both adrenal glands. And in that case, we want to think about sparing part of the adrenal gland so that the patient can avoid being on steroids if both of the adrenal glands need to be removed at some point. Right? So it's appropriate to think about what's called a cortical sparing adrenalectomy, which means partial adrenalectomy, preserving some of the adrenal gland if there's a low risk of it being malignant or cancerous, and we think that the risk of recurrence is not too high, and we think that we can leave enough of the adrenal tissue to have enough function that you don't need to be on steroids, right? So we don't want to sort of go through this and leave you with some adrenal tissue, which might eventually lead to recurrence if we don't have a good chance of letting you be off steroids.
Good point. Yeah, so there's an important diagram in the lower left here, which shows the medulla. The medulla is like the inside purple triangle part, and those are the cells that give rise to pheochromocytomas. The cortex is the outer layer, like the peel of an orange, and that secretes the steroid hormones. Now, most people, when they hear steroid hormones, they think of Barry Bonds and athletes. It's not those kind of steroids. We're talking about a specific steroid hormone, a glucocorticoid hormone called cortisol. And of all the hormones made by the adrenal gland, cortisol is the one that is the most essential to life. So if you don't have any adrenal glands, the thing you got to be watchful of is not enough cortisol. And we may be able to go into that more during the Q&A.
Okay, so just to show you some examples, in this case, for example, this is a patient who had 2 separate pheochromocytomas. So clearly it's not possible to leave some of the adrenal tissue behind because there's a second smaller pheochromocytoma. In this case, this patient had a pheochromocytoma here, but you can see it was sort of on the edge or the periphery of the adrenal gland, and so we can leave some of the normal adrenal tissue behind.
Yeah, that's the best. I mean, a lot of whether or not we can spare cortex is the luck of the draw. Right? How big is the tumor? Where inside the adrenal gland is the tumor arising? It's not enough to leave cortical tissue. The cortical tissue must have a blood supply in order to function. So all these factors sort of come into play.
Okay, some advances in the surgical technique. So this is how we do a lot of our operations. We do them through the back, through a laparoscopic technique, but rather than having 3 separate incisions, we can do the surgery through just 1 incision here. So we just have 1 little scar here. We put this device that allows us to put our camera and 2 working instruments, and then you can see the scar at the end of the operation. So we can often do this entire operation through 1 small little incision. Okay. Another sort of advantage of being able to do it through the back, sometimes people present with bilateral tumors, or pheochromocytoma in both the left and the right adrenal glands. Traditionally, you have to remove that one at a time, and that can be a very lengthy operation with a long general anesthetic. However, if you're doing it from the back and you have 2 surgical teams, as you have here, you can see this is Dr. J and myself, then you can actually remove both of the adrenal glands at the same time. So this operation is done, in only about a couple of hours of time to remove both of the adrenal glands. But obviously, you need a very specialized team with multiple surgeons to be able to do this.
And we weren't just showing off here by doing both at the same time. It's just that we were able to reduce the likelihood of a blood clot in this patient by reducing the surgical time.
That's right. Okay, a lot of patients have questions about the expected recovery after surgery. For laparoscopic surgery, it's usually just an overnight stay in the hospital. Most of our patients do not need to be in the ICU as long as they have a good alpha blockade before surgery. And we stop that alpha blocker immediately after the surgery. In terms of recovery from the back, I tell patients you'll feel like we kicked you in the back, and that will last for about a week, but you'll otherwise be eating fine and feel okay. And then doing it from the front, patients often have bloating and gas and shoulder discomfort from the gas that has to be insufflated in the front. And then what about post-operative testing? So it's really, again, goes to the biochemical testing, which is checking the hormone levels in the blood or urine. And we do that at about a month after surgery to confirm the patient was cured, and then on a yearly basis. And that's the main way to make sure that there's no recurrence, is by checking the hormone levels once a year. So we're going to just give you a couple of case examples, okay? This is a 31-year-old man who had a family history of Lindauer VHL, very strong family history, but he had no symptoms, was just living his life. Blood pressure was a little bit high, and then, actually ended up getting married, and his wife was pregnant, and ended up getting the gene testing to know that his child could be susceptible, and he did have a VHL gene mutation. You can see his hormone levels, normetanephrine was very elevated. And so in this case, you can see here the masses here. This is a pheochromocytoma on the right side. There's another one on the left side. And the right side, this pheochromocytoma was pretty big. You see this is the whole tumor here and the liver that's pushed up. So this entire right side had to be removed. But the pheochromocytoma on the left side, we were able to leave a small adrenal remnant over here. And then this is the Pheo that was removed. And we were able to do cortical sparing on the left side. And typically, the way that we check is the remnant working, is that we hold the steroid dose if the patient is on steroids, and then we check the cortisol or steroid level in the morning to see if the patient is producing enough on their own and if we can stop steroids.
This is a nice example. On the right side, that tumor is big, right? And so there's very, very little cortex. And what little cortex is it's just paper thin. It's like I took a cue ball and I dipped it in, wax, and the cortex is just that little thin layer. There's no way that's going to be safe. But on the left side, we had some favorable anatomy, we had favorable blood supply, and so we were able to spare cortex on the left side, but not the right.
Okay, so here's another case example. This is a 27-year-old man who had a family history, multiple people in the family that had throat cancer. He didn't have too much more detail than that, but he developed high blood pressure at age 24, which is pretty young to get hypertension. And this is sort of classic too. He was having back surgery for spine herniation, but his surgery was delayed due to high blood pressure. So if you have a pheochromocytoma that has not been diagnosed, so you've not been alpha blocked, and you have some kind of unrelated surgery, often that will precipitate a hypertensive crisis where the blood pressure will spike very high. So then during workup, he was found to have very high normetanephrine levels, and this is what he had. So he had a pheochromocytoma on the left side, which you can see here, and then he also had a head and neck paraganglioma. That's over here. This is on a whole body dotatate scan. So this, sort of classic for an SDH mutation. The pheochromocytoma we treat with surgery, which was successful, and the paraganglioma was observed. Okay, so this just leads us to our brief discussion of a head and neck paraganglioma. These are a little bit different in that they usually do not secrete any hormone. So most, Pheos and paragangliomas, they will secrete adrenaline hormone and cause the symptoms and high blood pressure. But the head and neck paragangliomas generally don't secrete any hormone. They are also much more likely to be associated with a hereditary condition, particularly SDH mutations. And because they don't have any symptoms of hormone secretion, they will often present as a mass. Okay, and the concerning part about them is that there are a lot of nerves in this area. So for example, the vagus nerve, which also controls your voice, is in this area. And sometimes these actually arise from the vagus nerve. So they can cause nerve issues like hoarseness. Sometimes the treatments, traditionally we would operate and remove these tumors, But because they are so close to blood vessels and nerves in that area, sometimes the treatment can lead to very significant morbidity or complications with nerve injury after the surgery. So we have really moved away from operating on these patients. And generally, we can either observe them if they're small, because sometimes, a lot of times they actually don't grow very rapidly. So we just observe them with serial imaging to see, and if they're not growing in size, we can just watch them. External beam radiation is actually fairly effective for stabilizing them, so it will not be curative. It won't make the tumor go away, but it will often make the tumor stable in size and not grow for many years. And then surgery would be a more rare case where, for example, if we're worried that it's about to impinge on a nerve and we think we can do a surgery safely to remove the tumor and prevent that nerve injury by the tumor itself.
Yeah, that's so important. I know we're starting to run out of time, but what you're probably noticing a pattern here is, yeah, we want to do surgery when it's safe, but we don't want to cause disability if we can avoid it. And, Eli, I was actually very, very touched by your comment about the feeling that a lion is chasing you. That really changed the way I'm, trying to interpret the patient's experience with this. But in treating these genetic disorders, and I'm figuring that many people on the line have a hereditary disorder, the strategy is we're not caring for you for just today or this operation. It is a chess game to be played 20 moves ahead to maximize the patient's health, longevity, function, prevent disability for a lifetime. So it's tempting sometimes as a doctor, as a surgeon, to look at the short time frame. No, in genetic disorders, you're managing a whole lifespan. And that's probably what you're hearing underneath what we are saying is a long game we're playing.
Okay, so our summary is that genetic testing really should be considered in all cases. It needs to be done in all cases of paraganglioma. It is done in many cases of pheochromocytoma, particularly in younger patients. Hereditary cases often occur at a younger age and in multiple sites. However, they are still usually benign unless you have that SDHB mutation. That preoperative alpha blockade and the experienced surgeon and anesthesiologist team, those are the critical parts for a safe and successful surgery. We talked about some of the advances in surgical technique, being able to do it through the back, perhaps through just one incision, and really just thinking about an individualized approach as far as when we can think about doing a cortical sparing or partial adrenalectomy, or even when surgery is appropriate at all, just thinking about each patient as an individual and what is the best thing for them.
Timing is key. Well, get the time just right. Don't rush. Be patient.
So thank you so much for your participation and attention. I'm going to stop sharing my screen and turn it back over to Eli for questions.
Thank you, doctors. That was very valuable. I hope everybody was able to pick up some nuggets that helped them. We did get some questions that came in along the way. First question, my doctor said they only remove about 20% of the paragangliomas now and prefer to just watch them. Can you give your thoughts on this?
Yeah, so this is sort of that slide that we looked at, particularly with the head and neck paragangliomas. In other cases of pheochromocytoma, really surgery is the recommended treatment unless there's a malignancy. In paragangliomas, even that are in the abdomen, they usually secrete hormones. Surgery is the treatment. It's really the head and neck paragangliomas where we really moved away from surgery, and we talked about the reasons. One is that they don't secrete the hormones that are dangerous for your blood pressure, and two is that surgery is associated with increased risk of complications because of the nerves in that area.
So much of medical decision-making centers around assessment of the risk-benefit ratio, right?
Right.
So, can we get, is this causing you to be sick? The thing in the head and neck, most likely not making somebody sick. Can we get to it? And what is the price we pay for disability, in terms of disability and complication rate in going after it? All those things go into the formula.
Right. I think that's important that you said when you mentioned that you're thinking of this as a chess game 20 moves ahead. And most patients are looking at them at the here and now of what they're dealing with. So I think that helps a lot. Next question. Can you please explain how UCLA and your center has changed its practices because of COVID-19?
Oh, great question.
Yeah.
Yeah.
So this actually really goes along with the discussion that we just had about what is the risk-benefit ratio to an individual patient, and then also to the healthcare providers and to our institutions. So I think what we have done, and most other places around the country during this acute period, is that we're only doing procedures that are emergent or urgent, where if we don't do this procedure within the next couple of weeks, the patient will have significant morbidity, complications, may even be life-threatening. And the main reasons for that are, one, we don't want to expose the patient to a potential infection, right? For most people, if you're otherwise healthy, you would be okay even if you got COVID, but there's data that if you get it right after a surgery, you might really get pretty sick. So we wanted to protect patients from that. And then the other part is, we didn't know to what degree we would surge in any particular area. So it's important to save resources for the event that we might need, hospital beds for patients who are sick with COVID, that we might need masks and our protective equipment. So for the past few weeks, we have been very selective and only doing really life-saving, very urgent operations. And I think that's been the practice in a lot of places around the country. I think as things are stabilizing, we might start to loosen that up a little bit. And I would say pheochromocytoma is a relatively urgent situation. Yeah. So we have still been operating on our patients with pheochromocytoma with the feeling that this is a more urgent case, and particularly at UCLA, because our COVID situation has been not overwhelming, we feel like we've been able to have that capacity.
Yeah. So here it's actually very thoughtfully managed. I'm thankful. I mean, I feel safe working here. And so, for example, I talked about the young man from this morning. He is going to have his surgery for pheochromocytoma in 3 weeks from now. We've set a date. He's going to come in 2 days before so he can get a COVID test, right? So now all of our patients who are coming in for surgery that is medically necessary to go within the next 30 days are going to come in, they have a COVID test. It's got a 98% sensitivity when correctly harvested from the nasopharyngeal area. And then the patients, if they have a valid COVID negative test, they can have surgery within 48 hours after having that test result. So we are still moving forward. And then I'm not going to go into all the additional precautions we're taking in the operating room. Of course, we have to protect each other. We have to protect our additional the patients. So it's proceeding, but in a very measured way and calculated way. We have other patients who have maybe non-urgent problems, or they're older and they're on immunosuppressive drugs. We're pushing them off as long as we can safely push them. The good question, timely question.
That's very good. Your patients are very fortunate for that. Third question that came in. My surgeon said it is unlikely they will be able to remove all my tumor, but referred to debulking. Can you please explain?
So that probably, in those cases, it would be either a very large tumor that's invasive or might be malignant with spread. Because otherwise, we should be able to remove the entire thing. However, if the tumor is already invasive into some of the surrounding structures, we see some lymph nodes in that area that seem to be metastatic, or perhaps it has already spread to multiple areas in the body, then just removing the actual tumor would not be curative. However, these tumors tend to produce a lot of hormone. So if we're able to debulk or remove the large percentage of the tumor, that should really lower the hormone levels and help with symptoms and safety of patients.
So it's important to define terms for this very important question. The best chance for cure, what I would want if I'm the patient, I want a resection with a negative margin.
Right.
What does that mean? It means the entire tumor has been removed and there is a halo of normal tissue around the tumor that is a safety margin that is also removed. Mm-hmm. That gives me the best chance of a long-term cure. Debulking means that you're leaving tissue, you're leaving abnormal tumor behind. That's a distant second best from a resection with a negative margin. So if at all possible, you want to find a circumstance where the resection, the complete resection is possible. This gets into, I have to talk about this delicately, but this gets into how do you choose a surgical team, right?
Right.
And don't worry about offending people, okay? There's a polite way to ask questions. I would ask, so tell me how frequently you and your team do this operation in a typical year, right? That number can't be 1. It can't probably be 4. You know, it has to be a little higher than that. And
Right.
then you'll see the more experienced teams are going to be a little bit more courageous. It's conceivable that a more experienced team might offer you an attempt at a complete resection with a negative margin, even if they have to take on a little bit more risk to achieve it. But you don't want to settle for second best when first best could have been possible, if that makes any sense.
It totally does. Thank you very much. Okay, fourth question that came in. Are there any situations where biopsy of a tumor is okay?
So usually we really don't want to biopsy pheochromocytoma because it can precipitate a crisis of high blood pressure, and usually is not helpful. So when we know that the hormone level is high and we see obvious nodule that's consistent with a pheochromocytoma, a biopsy really is not helpful. The only scenario I could imagine perhaps would be if you're worried about something that's metastatic. So you're worried about a spread of the pheochromocytoma to another site, and you want to confirm whether that's really a metastasis, and that might change how you treat the patients. You have to block the patient first with an alpha blocker. So you need to first get the diagnosis with the hormonal testing, have the patient well blocked with the alpha blocker, and only then get a biopsy. And really, I can't think of a scenario where you're biopsying adrenal glands, but maybe a distant site.
Yeah, so the only scenario is really rare. If you just want to confirm a metastasis and the patient is already alpha blocked so they couldn't have a crisis, and I'm going to add a third condition. Whenever we do something like this, we have one of our 4 anesthesiologists sitting there in case anything bad, they're just standing there in case anything bad happens, they're ready. Right. So it's a pretty rare circumstance.
Okay, thank you for that. This question is coming in from a patient who says, I'm 8 months out from surgery and still having symptoms. When will they go away?
Yeah, so I think it depends on what symptoms you're having. If it's the symptoms of sort of episodes of heart racing, sweating, kind of adrenal and hormone release, my first question is, have you had repeat hormone levels that have confirmed that you've been cured, right? So that's the most important thing. If the hormone levels are still high, then we're worried that you still have some disease. If the hormone levels have come down to normal, I think that you shouldn't have those types of symptoms really anymore. I do find that a lot of patients have more fatigue after after this kind of surgery, and I don't even know that it's specifically removing the adrenal gland as the fact that maybe you're used to having high adrenaline hormones and now they really have come down to a normal range. But we have found patients who more just feel like their stamina and energy is not quite the same as it was before surgery. That can take up to a year, to get better.
Yeah, agreed. First thing we want to do is make sure there isn't still evidence of hormone excess and tumor left behind or a second tumor. Barring that, the patient wouldn't be in danger.
Great. This is a non-surgical question coming in from a mother of a patient saying, my son inherited SDHA from his father who had malignant corridor para, which he inherited from his mother. Will my son have it worse than his father?
This is a question of genetic anticipation, meaning does the disease get worse as it progresses through generations? I don't think there is evidence of genetic anticipation for the disorder. The disease would be just similar. It will reflect what happened with the prior generation and not predicted to be worse or better.
Okay.
Do we think that was the question?
It seems like that's what they were asking. Okay, next question that came in, a question from Ellen. I am taking octreotide shots once a month. I hope I pronounced that correctly.
Yes.
I am waiting PRRT therapy treatment.
Yep.
It was canceled in March because of COVID-19. What exactly does octreotide do?
So octreotide is a somatostatin analog, so it's sort of a hormone that blocks the secretion of other hormones in your body. And there are certain tumors, like neuroendocrine tumors, that can secrete these hormones. So somatostatin can help to sort of block those hormones that the tumor is making, and it can help to first diminish symptoms that might be associated with these hormones, and also can help to kind of slow the growth of a tumor, and I would say more commonly used for tumors that have spread, because this is a more systemic treatment. The PRRT as well, that's a sort of a protein-based radiotherapy type treatment. Peptide-based, and so it affects the entire body. And so the PRRT as well can help to slow the growth of tumor. It's not going to be curative, but can help to make a tumor, often that's a metastatic tumor, to be stable.
Yeah, this is a very complicated question. So I gather that this question is being asked by someone probably whose pheochromocytoma has come back, possibly a malignant tumor. PRRT is a radiation treatment that goes specifically to the peptide receptors. It's peptide receptor radiotherapy. The question is about the octreotide. So remember, when we're dealing with diseases of hormone secretion, there's sending the message and who's listening to the message. You can influence the disease on both ends. Octreotide would tend to suppress the secretion of the message and potentially have a small effect on the growth of the tumor. We don't use octreotide too often in managing really palliative treatment, managing malignant pheochromocytomas. We tend to give a little bit of the receptor blocker, just a low dose that's tolerable.
Got it. Got it. Okay. Thank you. This next question is from a surgeon. Any special approaches for anesthesia to preserve remaining nerve function for patients with prior laryngeal nerve damage during intubation?
So question from a doctor about anesthesia to preserve laryngeal nerve function. So that would mean in patients had prior resection of a paraganglioma or some other neck tumor, right? Has a vagal injury maybe on one side. And then what do we do to preserve the other side?
So that's really a case of when to decide to operate. So if we're understanding correctly, this is a patient who had a head and neck paraganglioma that has been removed. And oftentimes those are growing from the vagus nerve. And when you remove it, you're going to sacrifice that nerve, which controls the laryngeal function. So if you now have one on the other side and it's also arising from that nerve, sometimes there is no way to protect that nerve. So it's really a decision of trying not to operate in those cases.
Yeah. I don't know what can be done to change the anesthetic. You
I
know,
think the question is with intubation, if there's a different technique.
I'm not sure that would change much. You might want to use a nerve monitor as part of your intubation, which will not help you find the nerve, but will let you know whether or not it's functioning at the end. Sometimes we use that in cases like these where it's high risk, but yeah, try not to operate. Number one, if you have to operate, try to spare the nerve. Do your best technically. That's more the surgeon than the anesthesiologist. Use a nerve monitor, see if there's any nerve function at the end of the case. If it's in question, you may have to do a tracheostomy and then come back. Tracheostomy is a plastic tube placed here in the airway if there's an airway obstruction, and then come back another day and try to restore some of the function of the voice. Complicated.
Wow, sounds like it. Okay, this should be coming up on the last question or so. I have the SDHB mutation and had a bladder para removed 7 years ago.
Yeah.
I now have a tiny left side Pheo. What's the minimum size of tumor for surgery?
Great question.
That's a great question. Yeah.
This is all about the 20 moves ahead bit, the timing bit. It's perfect.
That's right.
Yeah, go ahead. Yes.
So it's not that there's a specific minimum, right? If we know there's a tumor there, we can operate at any size. The question is, when does the risk-benefit ratio turn in favor of us proceeding with a surgery? Typically, oftentimes the pheochromocytomas are not really functional. They don't produce a lot of hormones, and so they're about 3 centimeters in size or so. So in somebody who has an SDHB mutation, where we're expecting multiple areas of disease, we don't want to be too aggressive and operate too quickly because we want to spare the patient operation as much as possible. So it may be the case that we want to wait until it's hormonally active, producing a lot of hormones and symptoms, and perhaps growing to be, about 3 centimeters, in size or so. Having said that, with an SDHB mutation, it's more likely to be malignant. So we need to be very careful if we're going to leave that there. What if it spreads? With a different hereditary syndrome like VHL or MEN, we're not really worried about it spreading. So we feel comfortable waiting longer to operate. With an SDHB mutation, I would also have that concern that if we wait too long, there's a potential for it to be malignant spread.
And this is a very nuanced question. But what we know about this patient is it sounds like one of the adrenal glands is good. It sounds like one of the adrenal glands has no abnormalities, and the patient has been scanned.
Right now.
So what that means is we have a little more license to operate in this patient because the other adrenal gland will make cortisol, right? The life-giving stress steroid cortisol. So in this patient, I'm thinking that I wouldn't let it get much bigger than 2 centimeters. I would be scanning probably every 6 months. SDHB, you probably noticed, with a little anxiety of an SDH mutation, because that can hurt you. I've measured catecholamines every 6 months, a little more vigilant. Scan every 6 months. It gets to 2. Probably pull the trigger at 2.
Okay, wonderful. Thank you so much. So there were some more questions that came in, but since we're running out of time, for the questions that we didn't get to, we should have time tomorrow during the COVID-19 webinar to ask the doctors to provide answers. Or maybe if you guys don't mind, we can send them to you and just have them transcribed with your thoughtful experience. So a big thank you to you both for your time and dedication to our patient community. This webinar will be available in a few days' time via YouTube and on the website. And we're also going to intend to transcribe the Q&A portion so that you have that available as well. We encourage all the listeners to go ahead and sign up for our e-news and follow us on social media. If this information has been useful to you and you are interested in donating, you can do so at pheopara.org/donate. Special thanks again to Progenics for making this webinar series possible through an educational grant. We're so grateful. And thank you for everyone who attended today. Remember, you are your own best advocate. Don't be afraid to ask the questions, even if you're uncomfortable. You need to do so. Stay safe at home, everyone. And remember, we're stronger united.